Good morning also from my side. Welcome to today's educational resident morning round. It's my pleasure to introduce Victoria Pearl, who is a first-year resident at the Department of Visceral and Transplant Surgery. My name is Benedikt Reutersberg. I'm from the Department of Vascular Surgery, and it's a pleasure. Thank you.
Thank you very much for the kind introduction, Benedikt. I'm delighted to be here today to talk about acute lower extremity ischemia. So let's begin this presentation with clinical cases. Looking at these two pictures, we can see two different forms of ischemia. One of them is the acute form and another one is the chronic form. This is an important differential diagnosis for today's topic because we do have more time concerning intervention. The acute form, however, represents a vascular emergency situation. So on the left-hand side, we do see Mrs. X. She's 54 years old and she presents with extreme pain for 1 hour in the right foot, sensory loss, and she's unable to move the toes. The foot itself presents cold and white. Concerning comorbidities, she presents with atrial fibrillation and mitral stenosis. On the right-hand side, we see a 67-year-old smoker with type 2 diabetes. He presents with rest pain in his left foot. We also see necrotic areas and pain in the right foot when he's walking more than 100 meters. So Mrs. X represents our today's topic, acute ischemia, where we do need urgent treatment. Mr. Y, however, presenting chronic ischemia, less urgent, mostly due to the fact that a collateral blood supply might already have developed over time. So to give you a short recap about Fontaine classification of chronic ischemia, with his right foot, the patient can walk less than 200 meters without pain, so this represents non-critical Fontaine stage type 2B. And on his left foot, we have rest pain and necrotic areas, representing critical Fontaine stage 4. Just a short overview of the differences between acute ischemia and chronic ischemia. In acute ischemia, it is always a sudden decrease in limb perfusion, often threatening the limb viability and a sudden pain. The symptom duration is less than 2 weeks, and it's mostly due to arterial occlusion, either embolic or thrombotic most of the times, and the incidence is 1.5 in 10,000. On the other hand, we have chronic ischemia, stenosis or occlusion of the aorta or extremity arteries, often with collateral circulation. Symptoms include rest pain, ulceration, and necrosis in the critical stage Fontaine type 4. And the risk factors, nicotine abuse, diabetes mellitus, and arterial hypertension lead to arteriosclerosis with a symptom duration of more than 2 weeks. The incidence is 10 times higher than in acute ischemia with 15 in 10,000. So today we will concentrate on the acute ischemia of the lower extremities. So I apologize for this overwhelming slide due to these numerous etiologies. Which of these subcategories do you think is the most important reason for acute lower extremity? So the answer is it's arterial embolus, mainly due to cardiac sources, atrial fibrillation most of the time. Another 20% is due to arterial thrombosis, and the remaining 10% is due to arterial injuries, vasospasms, vasoconstriction, or other iatrogenic causes. The clinical presentation depends on 4 main factors: the time course since the vessel has been occluded, the location of the affected vessel, the existence of underlying vascular diseases, and the possibility that collateral channels have already been developed over time. Symptoms duration, as we already said, is always less than 2 weeks, but could present from hours to days and range from new worsening claudication to even sudden paralysis. The diagnosis is a clinical diagnosis, so it's always important to check the clinics first. And if we do not have any chronic stenosis, then we can see 6 symptoms, all starting with the letter P, named after the US surgeon Gerald H. Pratt, who has described them first. The sequence of these 6 Ps is intentional. It always starts with pain, pallor, then paresthesia, pulselessness, and paralysis follow. And if it's not treated in earlier stages, it would result in prostration, a shock symptomatic. Rutherford classification is important for diagnosing acute lower extremity ischemia. So there are 4 stages. In stage 1, we do not have any sensory loss, we do not have any muscle weakness, and arterial Doppler as well as the venous Doppler signs, they are both audible. So this means the limb is not immediately threatened. And thus we have more time than in the following stages. Type 2A is indicated by a minimal sensory loss in the toes. There is no muscle weakness. The arterial Doppler sign is often inaudible, and the venous Doppler sign is audible. So the limb is salvageable if it's promptly treated. In 2B, the sensory loss is more than in 2A, and we also see rest pain. The muscle weakness ranges from mild to moderate. The arterial Doppler sign is inaudible, and the venous Doppler sign is audible. And what we need is immediate revascularization. And the last and worst stage of the Rutherford classification is stage 3. We can see profound sensory loss, paralysis, and both arterial and venous Doppler signs are inaudible. This means that the limb is already irreversibly damaged, and this also comes with permanent nerve damage. So what we can see here is a left common femoral bifurcation embolism, represented by this black arrow. So which one do you think is more dangerous? Is it thrombosis or is it embolus? It's embolus, and this is due to the fact that there is often no collateral blood supply, so the treatment is really urgent. And it often occurs in young patients with no comorbidities that could potentially die if not treated urgently enough. So this imaging modality that you can see on the picture right here is catheter-based arteriography. And it offers the possibility that you can immediately treat and diagnose. And the side effect is that it is an invasive imaging modality with increased morbidity and increased mortality, and sometimes it is difficult for the catheter to go through stents or pre-operated vessels. So this is the reason why, for diagnostic reasons, duplex ultrasound and CT angiography are safer and more commonly used. So this is a short slide comparing the 3 most used imaging modalities. As we already said, duplex ultrasound and computer tomography, angiography are the 2 mostly used ones for diagnostic reasons. They are both fast, they are both easily available. Duplex ultrasound is a cheap imaging modality, and you can easily assess the anatomic location as well as the degree of obstruction. However, there is a lack of 3D cuts, which we do have in CT. And we can also visualize calcifications, stents, and bypasses. Digital subtraction angiography, which we have seen on the picture before, has been the gold standard for diagnosis in earlier times. Nowadays, it is rather used as a complementary strategy in therapeutic approaches. And the reason is because it's invasive, and it's also possible that you fail to see a popliteal aneurysm, which you really need to rule out due to the complex treatment strategy and a possibly high and the associated high frequency of major amputation in these patients. The role of MRA in diagnosing and in treating the acute lower extremity ischemia seems limited. So concerning treatment, I'm sorry again for this busy slide. This is the decision-making algorithm by the European Society for Vascular Surgery of 2020. And due to the countless etiologies of acute ischemia, the treatment options are various and they depend on the underlying cause as well as the Rutherford stage. So we will go through it. So first of all, one should clinically confirm the ischemia and start heparin intravenously and oxygen. Second of all, it is important to assess the correct Rutherford stage and then decide if an urgent imaging needs to be done. And then, concerning treatment, it varies from conservative treatment to endovascular or surgical approaches or even to amputation. And during treatment, switching of these techniques or combining them is possible as well. So, initial management is indicated whenever you can clinically confirm acute limb ischemia. What we need is appropriate analgesia, and we need an administration of unfractionated heparin. Initially, it's 5,000 units intravenously, and measures that could also be beneficial are intravenous hydration, supplementary oxygen, and the anti-Trendelenburg position that you can see on this picture. So this is an overview of the three main treatment options. It's open revascularization, thrombolysis, and other endovascular techniques, which are the newest ones. And it is also possible to combine them in terms of a hybrid therapy. Open revascularization includes thromboembolectomy and surgical bypass. Thromboembolectomy includes the Fogarty balloon catheter that has been invented in 1962 by the US surgeon Tom Fogarty. It's mainly used for embolic occlusion. So how does it work? You make a single incision and go through either the femoral artery or through the popliteal artery. And then the catheter passes through the thrombus itself and lies down. And then the balloon gets filled with fluid, gets expanded. The catheter is getting pulled back and should thus remove the thrombus. So in case of thromboembolic occlusion, depending on the length of the occlusion, surgical bypass is indicated. This is often the case in acute on chronic ischemia. Vein grafts did show better patency in the recent studies. However, if the treatment needs to be done very urgently, one should rather use prosthetic grafts. This is also the case if no appropriate vein is available. Let's see the next treatment strategy, thrombolysis with fibrinolytic agents. It's either done systemically or directly into the artery. Nowadays, systemic thrombolysis is not recommended anymore. Percutaneous catheter-directed thrombolysis is indicated in Rutherford stage 2A and 2B, but you have the major risk of significant hemorrhage. So one must consider these contraindications. And the Working Party on Thrombolysis in the Management of Limb Ischemia has introduced absolute, relatively major, and relatively minor contraindications for thrombolytic treatment that you need to consider. Other complications are distal embolization, progressive ischemia, and compartment syndrome, which will be discussed later in this presentation. So every time you have major bleeding, which occurs in 8 to 10% of patients, you need to immediately stop thrombolysis. If there is distal embolization, we need to switch to an open surgical or endovascular approach or other endovascular approaches. If no improvement of the treatment strategy occurs in 6 to 12 hours, we need to change the treatment strategy. Let's see other endovascular techniques. So the goal of other endovascular techniques is to restore blood flow in the ischemic limb. And on pictures A and B, we can observe the treatment of a femoropopliteal stent occlusion, and on picture D, we can see the extracted full-length thrombus removed by thrombus aspiration. There are several commercial aspiration catheters available. For example, rapid exchange systems that are also used in coronary arteries or vacuum pumps. Complete removal is more frequent if it's an artery which lies above the knee, and it has also shown better outcome when the thrombus is acute, meaning it is less than 14 days old. If it's used first line, it could reduce the need for thrombolysis, but it's also a possible treatment strategy if thrombolysis has failed. So a study at the University of Heidelberg of 2017 showed that the Rotarax system, which is an endovascular mechanical thrombectomy system, represents a safe alternative to thrombolysis with a significant reduced rate of major bleedings and a lower overall hospital duration. Nowadays, patients tend to present with complex multi-level occlusive diseases. This is why we need hybrid treatment. So either endovascular approaches are done after surgery or the other way around. And if we have an underlying chronic stenosis, we could use balloon angioplasty or stenting to remove the underlying condition. So the optimal treatment is done in hybrid theaters with a full range of open and endovascular interventions during a single procedure. So the question remains, which therapy seems to be the best one? Unfortunately, this has not been yet conclusively clarified. There is a lack of randomized controlled trials. In the treatment of acute lower extremity ischemia, causes could be mainly to the heterogeneity of the patient, which makes it difficult to compare the study results. Researchers face several problems due to, amongst others, the various treatment options that depend on the etiology of the disease, the patient's characteristics, the anatomical location and extension of the disease, as well as the severity of the ischemia. So if we take a closer look at study results in the past, studies from the 1990s showed an equivalent treatment result of surgery compared to local arterial thrombolysis in terms of amputation-free survival up to 1 year. Since then, there has been an evolution in endovascular techniques with better equipment and skills. So therefore, I would like to present you recent results of 3 studies which compared endovascular and surgical approaches. So the first one is a US meta-analysis published in 2017. It included 1,773 patients, and it did not find any difference in morbidity or mortality of endovascular versus surgical approaches. Secondly, a US propensity score weighted analysis of 2018, including 1,480 patients, did find less major amputation rates at 30 days in endovascular approaches. And now I would like to focus on the largest study today, including more than 16,000 patients from 2018. This is a Swedish multi-center retrospective registry study, and they found a lower overall mortality at 30 days and at 1 year, as well as a higher amputation-free survival at 30 days and 1 year in endovascular approaches compared to surgical approaches. So you can see these results visually here in these 2 Kaplan-Meier curves. Not only did they find a higher overall survival in endovascular treatment, but also a significantly higher amputation-free survival. So although the Swedish study tended to show a better short and medium-term outcome in endovascular approaches, these results were not conclusive. The question, which is the best treatment strategy, remains, and further studies are definitely needed. But to show you an outlook, there is an ongoing prospective multi-center observational study on acute lower limb ischemia sponsored by the University of Innsbruck. And their goal is to identify current management strategies and evaluate outcomes of acute limb ischemia in vascular centers across Europe. The Department of Vascular Surgery at USZ is also taking part. Primary endpoints are limb salvage and survival at 30 days, and secondary endpoint is limb salvage at 90 days. The study also includes the influence of clinical factors on outcome and the need for reintervention. Planned end of the study is February 2023. And since, unfortunately, reperfusion is often not enough, I would like to mention one of the worst complications. Tissue damage can be aggravated after reperfusion. This reperfusion injury results in more tissue damage, the release of oxygen-free radicals, and infiltration of neutrophils, causing vasodilation, capillary leakage, tissue edema, and this results in compartment syndrome. In compartment syndrome, the intracompartmental pressure rises. If it's untreated, the limb becomes more ischemic and limb loss could follow even with previously successful reperfusion. So the main complications are leg amputations and occasionally even death due to rhabdomyolysis and tourniquet syndrome respectively. The diagnosis is made clinically by severe pain, swelling, tenderness of the muscles and sensory deficits. And if there are already motor deficits, full recovery is only possible in 13% of patients. So the treatment seems pretty straightforward, just cut the fascia. But it is also important to do a prophylactic fasciotomy after revascularization due to the low sensitivity of diagnosis and often late diagnosis. At USZ, we do prophylactic fasciotomy in Rutherford stages type 2. And on this picture, you can see how it's basically done. So we need 2 incisions, one medial incision and one lateral incision. And this opens 2 compartment segments at one time. So I would like to finish this presentation with a few take-home messages. Acute lower extremity ischemia is an acute emergency with the risk of irreversible ischemia and death if it's not treated. Early diagnosis and rapid initiation of therapy are essential. You should always check the 6 Ps, and checking the 6 Ps and the Rutherford classification are the key for the treatment decision. If possible, a referral to a center with a 24-hour full vascular service is highly recommended. We should always consider new endovascular techniques, namely aspiration and mechanical thrombectomy. And there is the risk of reperfusion injury, compartment syndrome, and that's why prophylactic fasciotomy in Rutherford stage type 2 is really important. So ideally, the treatment takes place in hybrid theaters where all options are available. Thank you very much for your attention.
This was an excellent presentation. Nice slides, good presentation, good English. So credit goes to our resident. So I would like to start with the first question and then I transfer the discussion to you. At USZ we have 3 interventional disciplines. So we have you guys from vascular surgery, we have even and very advanced angiology, which doing also interventions, and then we have our interventional radiologist. All these 3 parties could do basically these kind of endovascular treatment. So who should do it? Should we not limit this to 1 or 2 and say to the others they should not do it?
So that's a very, very political question. And the problem is that I prefer to do, as a vascular surgeon, to do everything at once. And I can do the endovascular approach, I can do the conservative approach, and I can do the surgical part in one stage. It's historical that these departments exist. The best option in these cases is to discuss these patients case by case and look who has time, who has the available room to do the operation and do it as quickly as possible in the sake of the patient. So we were very, very much gifted to have these three options to get the patient treated as fast as we can, but we shouldn't forget that we have all these three options. So it sometimes ends up that a patient is only treated endovascularly in an acute or chronic stage, where we've heard that a surgical procedure might be better with a bypass operation, and has a huge vein in his CT scan, which can be used as a graft. And in the end, he comes 2, 3, or 4 times, will always be treated endovascularly because he was in that department in the first place. So at the USET, we are still trying to improve this treatment options. I know from Bern they have a multidisciplinary team in discussing the patients in a team setting, and I think we are trying to move in this direction here as well. So thank you very much.
Thank you.